Good afternoon, everyone. Thank you so much for joining us this afternoon for our IHER Health Equity Seminar Series. My name is Utsa Khatri, and I have the great honor and pleasure of introducing our speaker for today. So our speaker today is Dr. Emily Wang, who is a professor in the Yale School of Medicine, the director of the SEICHE Center for Health and Justice, the director of the Health Justice Lab, and a co-founder of the Transitions Clinic Network. She leads these initiatives with focus on identifying and applying strategies to improve the health of individuals and communities impacted by incarceration. I will not embarrass Dr. Wang by mentioning many of the accomplishments and accolades that are missing from this very brief bio, but I do have to mention that she has recently been awarded the MacArthur Genius Grant in recognition of her work and has also been elected into the National Academy of Medicine. I will also add that Dr. Wang is a brilliant, kind, and generous person with a long-standing and unwavering dedication to a population that is too often underlooked and pushed to the margins. Dr. Wang has inspired my own career and serves as a mentor or a figurative North Star for so many others who work in this space. We are beyond thrilled to learn from her today. Thank you so much for joining us.
Thank you so much. It's a real pleasure and honor to be here in community with you to learn, especially from you, Utsa, and the IHER team. There are so many scholars at Mount Sinai that are doing brilliant work. And so I'm really excited to be here to learn with and from you all. I'm going to share my screen. Okay, can you see me? Can you see the slides and see me? Great. All right. So I'm going to go ahead and get started. Last year marked the 50th anniversary, 2023, of mass incarceration. And for too long, our primary policy solutions on public safety and public health have been ones with that I feel are without a critical component, and perhaps the most important component for sustained reform, namely the input of people that have been disproportionately incarcerated. And so a primary goal of mine is to create systems that include their perspectives, values, and expertise into the policies, practices, and the institutions that are focused on health, well-being. And I've done so by applying a community-based participatory research strategy approach to mitigate the harms of mass incarceration. And so I wanted to start the talk today, this afternoon, with a picture of our first cohort of Transitions Clinic Network community health workers. This is a picture from almost a decade ago. And I start here as a reminder that it's these people that are the biggest assets to our science, individuals that have been incarcerated themselves, working as community health workers in our healthcare systems. They embed new vision, new light into our science, into health system transformation, and into the institutions where change needs to happen to address mass incarceration. Doing work alongside people with histories of incarceration isn't feel good, it isn't nice, it isn't kind. By including their expertise, I found that it makes our science more accurate, our work more honest and urgent, and we are able to find new approaches to solve some of the most complex issues that beset our health system. So for the next hour or so, I'm going to talk first about the clinical epidemiology of incarceration, and then transition a little bit to talk about the health risks of incarceration. I will give two examples of using CBPR to address the health impacts of mass incarceration and end with some concluding thoughts. And so to start, there are 7 million individuals in total that are currently under the jurisdiction of the criminal justice system. That's 1.9 individuals that are behind bars in prison or jail on any given day. 5 million individuals that are supervised in a community system of correction. So either on parole, they've served their sentences and released into the community and serving the remainder of their sentence in the community, or in probation. They've been sentenced with a crime and served their sentence in the community. After 5 decades of mass incarceration, 19 million individuals have ever been convicted of a felony. Almost 80 million individuals in the United States have a criminal record. And importantly, of course, this has bearing not just for those that have criminal records or those that have been incarcerated, but nearly 50% of all U.S. adults have had an immediate family member, a child, a loved partner, or a parent who's ever been to prison or jail. And on a total, that includes 113 million individuals. Those who are incarcerated are disproportionately poor men of color. Using life table measurements, these data were just rerun in 2023. And what they estimated was that 1 out of 10 men in this country have had a lifetime likelihood of imprisonment. And when you break that down by racial categories, it's approximates 1 out of 20 white men have been incarcerated. 1 out of 5 Black men have a lifetime likelihood of being incarcerated, and for Latino men, it's 1 in 8. These data have improved in meaning that the racial disparity in incarceration has shrunk. In 2003, the statistics were that if you were born in 2003, you had a 1 in 3 lifetime likelihood of being imprisoned. Similarly, while incarceration is far less likely for women, Black women are way more likely to be incarcerated compared to white female counterparts. And then, of course, Black families are disproportionately more likely to be affected by incarceration. If you look here at the rightmost corner, almost a quarter of all Black Americans have 3 or more immediate family members who've been incarcerated, compared to 5% of white Americans. And so, based on the work of a sociologist, Becky Pettit, the New York Times, almost a decade ago, ran this headline that there were about 1.5 million Black men who are missing from daily life between the ages of 25 to 53 because they were either dead or incarcerated. And this was one of the infographics that came from the Times article. In the yellow places, they're disproportionately missing from daily life, and purple places, they're overrepresented. And while it's long been known that Black men are more likely to be locked up, more likely to die at an early age, the scale of this combined toll is enormously large. Then more than 1 out of 6 Black men weren't around to be parents, husband, working citizens. And when you break it down, higher imprisonment of Black men accounts for 600,000 of the men who are missing, and early death is thought to account for 900,000. Homicide is the leading cause of death for young African American men, and heart disease for older Black men. And this missingness of Black men has significant bearing for our understanding of the health of Black men, of health disparities, and our achievement of health equity. So I want to dig into this a little bit more. We did a study just to look at how mass incarceration has impacted the study of health disparities, and especially how incarceration might impact loss to follow-up in large cohort studies. So we identified all studies funded by the National Heart, Lung, Blood Institute, which has followed participants for at least 2 years and intentionally recruited both Black participants and white participants with an aim towards understanding racial disparities in health, and asked a basic question: how many of them followed their participants recruited in the community into a jail or prison? And how many studies actually ask about the exposure to incarceration, given how prevalent mass incarceration is in this country. And what we found was that none of the studies in their IRB had followed individuals to a prison or jail. And only one study, Cardia, asked a single question at baseline 30 years ago, and then again follow-up to about exposure to jails. And so our next step then was to calculate how much of the missingness, how much of the loss to follow-up could be estimated due to incarceration. And here on this figure, you see the data for Black men. So in red, you see the actual loss to follow-up of Black men in large NHLBI trials and cohorts, and ones that y'all will know. So MESA, Jackson Heart Study, ERIC, Cardia, you can see this on the y-axis. So in the red, again, it's loss to follow-up. And then we again used life table measurements and estimated the loss due to incarceration given period of recruitment, where they recruited, and the age groups that they recruited. And what we found was that anywhere between 15 to 65% of the loss to follow-up in these studies among Black men was likely due to incarceration. And so this is one study, but the point that I want to make here is that the scale at which we've incarcerated in this country and have incarcerated for the last 5 decades has to be impacting our knowledge of racial health disparities, as most studies don't follow participants into prisons and jails, don't include institutionalized participants, and don't even ask about exposure to incarceration. So I want to shift now to where my lens is often focused is on health and even healthcare delivery, especially in particular to illustrate how power structures are in medicine, and especially for those who are justice involved, and perhaps to start shining a light on why I've used this community-based participatory research approach in our research studies. And so these pictures here come from San Quentin in California, where I had a longitudinal primary care practice as a resident. And I share these with permission from the Department of Corrections, but also with the patients in this picture. And I want to make the first point is that after 50 years of mass incarceration, what we're seeing is a whole generation of people that are aging behind bars. Oftentimes, you get the impression that those that are incarcerated, again, those 1.9 million that are behind bars right now, are young and healthy. And the reality is that 85% of individuals have a chronic medical condition that warrants longitudinal primary care. They have disproportionately high rates of conditions like hypertension, asthma, COPD. This gentleman here has COPD. Infectious diseases like hepatitis C, HIV, certainly because we've criminalized substance use disorders, have higher rates of opioid use disorder, cocaine use disorder, alcohol use disorder, and also mental health disorders, including depression, PTSD. And so again, you'll see on TV, it looks like they're out exercising in the yards. And in fact, many individuals are aging behind bars. And just take a look. This is just a regular clinic, again, at San Quentin. And there's a gentleman here that's getting his nebulizers, and another guy that's waiting to see his doctor who's held in a cage while he's waiting to see a physician. And I think what drew me to this almost 2 decades ago was the fact that healthcare is constitutionally guaranteed in prison and in jail. And it's one of the few places in the United States, certainly prior to the passing of the Affordable Care Act, where there was a constitutional guarantee in care. And so what this means is that you have this large population of young adults, often from racially minoritized communities, that come into prisons and jails, and it's often their first time of accessing healthcare as an adult, and they do so behind bars. We have found in our studies and others that 40% of individuals that move through carceral systems are actually newly diagnosed with a chronic health condition while they're behind bars. And so while healthcare is constitutionally guaranteed, it's important to note that access is limited by institutional policies. And I'm sharing this photo here, and I just want you to turn your attention to that pink slip. That's a kite. And at the time, this is the form that patients have to fill out to see a physician. And so you fill this out, and the first person that sees that form, and for both acute or kind of management of chronic conditions, is a correctional officer. And so the correctional officer then evaluates whether or not this warrants it's a medically necessary a symptom, and then a nurse sees it. The nurse deems it with medical necessity, then you see a physician. So, you can see that there's lots of barriers to actually accessing care, different than in the community. We see, if you need to see a physician, you can always roll up into the emergency department, the very least. But here, there's all sorts of different barriers to getting care. Another thing that's important to remember is that many individuals across the country, when they're incarcerated, still have to pay a copayment to see a physician. And so in Connecticut, where I practice medicine, they have to pay $3 to see a physician. And, $3 doesn't sound like much, but $3 is equivalent to 4 days worth of pay. So you make 75 cents a day if you have a job. And so and if you're lucky enough to have a job. And so again, you can see how the ways that patients move through the healthcare system behind bars is notably different, and with unique barriers to access to healthcare that are different than those in the community. Here, this photo is from our daily rounds of a patient who had just been diagnosed with hypertension, with hypertensive urgency, and had come back, and we're rounding on him post-hospitalization. And, I want to illustrate that kind of the self-management of chronic conditions is actually very difficult. Again, here you can see that when we're rounding on him, you have to throw the cuff through this hole here. The patient straps it on themselves. There's no privacy. You can see there's a gentleman next to the patient who can overhear everything. This individual, newly diagnosed with hypertension, every morning is woken up at the crack of dawn by a correctional officer, has to make the med line. And in the med line, the nurse is giving him, let's say, his amlodipine, his hydrochlorothiazide, his new blood pressure medications. She gives it to him, a cup of water, swallows it, checks to see if he's cheeked it, and then he returns back to his cell. And so you can see here that adherence is almost 100%. But there is no sense of kind of the patient's own need to develop their own skills for managing his own chronic conditions. Patients with diabetes, rarely, if ever, have the opportunity to use a glucometer. They never drop their own insulin. And in fact, we've done studies, and others have found this too, that if you choose not to take your insulin, for instance, in a day, oftentimes patients are sent to administrative segregation because they're bucking up against the rules. And so the whole experience of healthcare is passive, and it can be a punitive one. Quality of care is also quite variable in our nation's correctional facilities. There's 6,000 correctional facilities across the country, many more jails, almost 4,000 jails, 2,000 prisons. And again, this is inclusive of the federal prison system. And if you've seen one, then you've seen one. And so I think the important thing here to note is that care is really variable to incredibly heterogeneous, and it's we actually don't have a national monitoring system for how healthcare is delivered behind bars. And perhaps the best example of this is how carceral systems manage opioid use disorder. So OUD is highly prevalent in correctional systems, again, given the criminalization of drug use. And in a national survey in NSDUH, 40% of individuals that use heroin have spent time in a prison or jail in the past year. So it's highly common, highly prevalent. And these are the individuals with the most severe of opioid use disorder. In spite of the known efficacy of methadone and buprenorphine in particular for reducing death and also reducing return to carceral systems, these medications that are FDA approved for opioid use disorder are only available in some prisons and under certain circumstances and a handful of jails. And the last time this survey was done, it was about 2% of facilities across the country had all 3 FDA-approved medications. This has increased and improved in the last few years, but it's still the vast minority of systems that have access to these medications. And this is in part due to the fact that in most correctional systems, security oversees healthcare, not doctors. And so it's, again, a whole different system that kind of it governs the healthcare behind bars. And then I always want to kind of, I almost always share this photo of a patient, much like how I started with COPD, who's oxygen dependent, who's being held in solitary confinement. And you can see very clearly in this picture that his tank sits outside of this window. And every once in a while, you would hear him banging on the door because the tubing has gotten kinked and he couldn't breathe. And of course, the rationale for this is that it's dangerous from a safety standpoint to have the tank inside. But what's clear to me in this photo is how health is utterly secondary to punishment, to control, and safety. And you have to imagine that this patient, perhaps this patient who was first diagnosed with chronic conditions behind bars, is mistrustful of the physicians, the healthcare providers, the whole healthcare system at large, because we are complicit in these health-harming behaviors. How could you trust a system that treats you in this way? And so, I think it's important to note that, of course, almost everyone returns back home into the community that has cycled into the carceral systems. It's about 95% end up going home. And then over years, 2/3 will go back into the healthcare system behind bars. And so there's a real cycling between these two very different healthcare systems. And so what happens when a person walks out the door? So first, if you think about kind of discharging folks from the hospital, we always have a discharge plan. Individuals can spend, in prison, the mean time is 2 years. And the majority of individuals are still discharged with limited discharge planning. And what it means is short supply of medications, 7 to 28 days in most settings. Many are released without their health records, and many are released without a primary care appointment. And so again, they're coming home to our healthcare systems, often never having had to navigate the community health systems with very limited discharge planning. Many are released without health insurance. And again, in the states that have not expanded Medicaid under the Affordable Care Act, and they come home without insurance. And even in states where Medicaid access has been expanded under the ACA, many states have a lapse in Medicaid. They terminate Medicaid and Medicare. And so when you're coming back into the community, these benefits have been turned off. You have to reapply until you're back on. Notably, and I think importantly, under the Consolidated Appropriations Act of 2023-4, this will end by statute in 2026. There have been studies showing that there's discrimination based on having a criminal record within the healthcare systems. And then even after having served your full sentence, there are additional barriers that are leveraged on those with criminal records. In certain states, there's lifetime bans for individuals to getting food stamps, WIC, Section 8 housing, even voting for those with criminal records. And so, not surprisingly, at all, there's a significant worsening of almost every chronic medical condition that's been studied, including HIV, hypertension, cancer, substance use disorder. And there's a significantly high risk of hospitalizations and a high risk of death that are largely preventable. The most common causes of death, and this has been affirmed in multiple studies across states, are overdose, heart disease, cancer, suicide, as well as gun violence. And so deaths that are largely preventable. And, I think it's important here to note that oftentimes, as with healthcare providers and the media, certainly it's easy to think about kind of what's going wrong in carceral systems. But I take a pause here to state that, you know, in our community health systems too, we have a lot of work to do. And I often think about kind of, in fact, counter to what you might think, that there's a real worsening of health outcomes when people come home. And, you know, in Mount Sinai, Yale, and other places all over the country, we have, at least at Yale, ceded our powers to the carceral health systems. These are pictures of patients that are in the community that are incarcerated, that are shackled. And so how do we then undo this harm? And I think that given these power structures that we have both in the community health systems as well as in the carceral systems, I've thought hard across my career about how CBPR can be an approach to undo this harm and start undoing these power structures. So before I start, I wanted to say is that I'll just define CBPR. Probably many on this Zoom know what CBPR is, but it's community-based participatory research. And I want to state outright that it's an orientation to research. So fundamentally, what it does is it changes the role of researcher as not the expert in the room, as recognizing that there's expertise among those who've lived in the research that we do, those that have been exposed to the health harms of incarceration, and people that are incarcerated, their family members, and even increasingly, we've started working with those that work in carceral systems. And it says that you too have critical knowledge and that your expertise is important and also is wholly complementary to the work that needs to happen. CBPR then isn't a method or a set of methods, but it's an applied approach. And the goal is then through research to influence change in community health systems, programs, or policies, and really to invert normative power structure. So it's in the conduct of research and where power is shared between researcher and community members, and in this case, those that have been impacted by incarceration, starting from the very beginning, thinking about the questions that you ask, and then about the study design, the implementation, and then the dissemination, that you really are working to influence change, and also explicitly invert normative power structures. All right. So during residency, almost 20 years ago, I became obsessed with what I thought was going to be a pretty easy question to tackle, which are the transitions of care for people that are just released from carceral systems, and really focused on thinking about, hey, I'm a primary care doctor in an internal medicine residency. Where are the ways that we could mitigate the harms of incarceration just by easing these transitions? And so in my training at UCSF, in San Francisco, there's a large and robust community of civil rights leaders who have been at this for far longer than I have, really fighting for the resumption of basic civil rights of people that have been incarcerated. And we partnered with them and conducted multiple focus groups among those that had been incarcerated, among people that were currently incarcerated, health system leaders that had criminal records, and designed a program in partnership with All of Us or None and Legal Services for Prisoners with Children called Transitions Clinic. And it was principled on the kind of fundamental belief that healthcare interventions that are the most successful are ones that people will use and that are tailored to their needs, their perspectives, and their values. And so at the core of this model is a community health worker. This is my late colleague, Jerry Smart, who is a community health worker that works in partnership with a physician here, Dr. Lisa Puglisi, and patients. And the community health worker was a critical component of what these focus groups identified as the missing link, the need to build trust in the health system, but also to navigate an incredibly complex health and social service system. And we're really focused on shifting, disrupting the status quo of primary care and creating a new paradigm of primary care where our community health worker would instead meet the patient prior to release, create a kind of a warm meeting, understand what their needs and priorities are. And then she, here, Juanita Alvarado, community health worker, would be the first kind of contact and connection when this person came home from the carceral system. Next, we would have a healthcare system where here the primary care provider knew that there was a whole system of care behind bars, knew how to get the electronic health records, knew how to screen for a person what their health risks might be given that they had been through a carceral system, and could talk explicitly about how can we keep you safe, how can we kind of help you prevent actually going back behind bars. Within the primary care system, it would be a place where it would be trauma informed, that the front desk staff wouldn't, if a person was 15 minutes late, they would still be able to come in. And it required kind of a redesign, recognizing that many of these individuals had never actually engaged in the community healthcare system and needed more hand-holding through basic federally qualified health centers and primary care programs. And then lastly, we would have strong connections to social service agencies and community organizations that are attending to these health-related social needs. So food programs to address food insecurity, housing programs, employment programs, civil legal programs. And these were kind of the primary components of our transitions clinic program. And early on, we saw the need, again, to study this program. And, I think it's important here that we created a wide group of stakeholders, including individuals that have been incarcerated, family members, organizations. Again, these two here, All of Us or None, are legal services or prisoners with children, which are national kind of advocacy organizations, but also deepened our connections to individuals and policymakers that would ultimately be sustaining such programs. So created ties to the Reentry Council, to the Department of Public Health, as well as to the San Francisco County Jail medical staff. And it was in these early conversations that we would discuss policies about what we would do at the clinic. Would we create urine tox? Will we do urine toxes at our clinic? We were offered space by the San Francisco County Jail to have a clinic space right across the street. And our patients, our individuals that have been incarcerated, were the ones that would help us guide policies that were consistent with their values. They said no to the space right across the jail. They didn't want to be reminded of the jail, but they said yes, urine toxicology, so long as we explain why we're doing this. And so this community advisory board then became kind of the bouncing ball, the place where we discussed all new ideas as well as our research plans. And what we did end up settling on was a randomized controlled trial. Again, talked a lot about the ethics of this at this time. There was no other system that was transitioning care for people that were returning home. And so what we decided what would be ethical was to have everyone get a 2-week visit to the Transitions Clinic program, and then people would be randomized to either transitions, to stay in our Transitions Clinic program, or get expedited primary care in the clinic and within the safety net system. And, these early conversations were important. They were especially important because we were designing a study that would bias ourselves to the null. In the other arm, they were also getting an intervention, but felt that it was important to be ethical in our randomization scheme. And so everyone from policymakers to our patients, our community advisory board, understood that we were, setting ourselves up maybe to have a null finding, but was okay with it. We also had long conversations about these outcomes. The things that move me aren't, necessarily reductions in emergency department use or even return to county jail, but felt that these were the outcomes that we really wanted to look at. so that a program like this, if successful, would be sustained. And these are what policymakers are most excited about, was kind of saving costs to the county. And so I won't spend too much time with this. We ended up finding that, again, in randomizing 200 individuals, TCM participants did have 50% fewer emergency department visits in 12 months, and no difference in return to jail. And we have subsequently, again, used CBPR across our transitions clinic network to build out the research that supports its growth and expansion into other communities. And currently, we have, over years, provided primary care to 10,000 plus patients leaving correctional facilities, have studied it, as I mentioned, showing that it reduces acute care use, reduces length of hospitalizations, even reduces return to the carceral facilities in Connecticut, and have worked with policymakers in community health systems and payers to implement this model. And so at this time, the network is led by Shira Shavit at the University of California, San Francisco, and we have 48 programs in 14 states and in Puerto Rico. And one of the hardest things I think about CBPR is really creating data platforms so that people that are engaged as co-researchers can actually analyze the data and come up with hypotheses. We've experimented with this and received PCORI funding to try to create a platform by which we could share data across our network to our community health workers, to our patients, to correctional policymakers that were working closely with us, and community health systems. And happy to talk about this a little bit later. This is harder to do than we thought it would be, almost as everything is, but we continue to try to iterate to think about how best to share our data back with participants, back with our stakeholders, and especially to generate new ideas and analytical tools. And so TCN now has become a platform where we're doing other randomized controlled trials. Right now, we have an ongoing trial where we're looking at opioid use disorder outcomes. And again, this is work that, because we've started using a CBPR approach, over time have been able to iterate and expand our ability to do high quality randomized controlled trials across our network among some of the most marginalized communities. Here, we have this randomized controlled trial, people with opioid use disorder released from jail, and again, have a high burden of exposure to the criminal justice system, high exposures, high risks of overdose. Again, the average among our participants was 5 times, and our participation rates in these studies have been over 80%. And so, given this, I think one of the most exciting things now that's happening is that across, having done this work for almost 15 years, in April of 2023, the Centers of Medicare and Medicaid Services announced for the first time that Medicaid funds could be allocated for the healthcare of incarcerated people through these 1115 reentry waivers. And CMS has signaled the importance of establishing infrastructure to improve transitions, and specifically cited the Transitions Clinic Network as important to leverage community health workers who are part of an integrated health team. And, I pause here just to say is that this work could not have been done if we had not been deeply partnered from the beginning with people who urgently felt the need to, again, study this, but also to disseminate our work and then sustain it and work closely with policymakers. And, oftentimes within our network, data and doing kind of quality improvement or even research is kind of the least sexy of what we do. But this is a picture that came from our last TCN convening, where we're working on trying to, oh, sorry, the slide didn't come out great, a white paper to create a set of program evaluation components and core quality measures for states implementing the 1115 reentry waiver. And because of the work that we've established over this years, this was, almost 150 people in a convening trying to think about what were the right set of quality measures that states should use to look at the fullest implementation of these 1115 waivers, and also what are the process measures? How could we look at whether or not the funds are being appropriately allocated to community health systems? How can we check on equity so that, again, as these programs get established in states, how do we know that the most marginalized among those that are incarcerated are equally getting access to the services that are being proposed? And so some of the challenges here is that there's so much work to be doing, even just in the day-to-day of primary care delivery. There's always a tension in our work with primary care and then actually pulling off the research. There's tensions, again, between building the capacity of our community and especially community health workers to really engage in research while we're attempting to build and maintain conducting high-quality randomized controlled trials. And many funding mechanisms simply don't account for the time and resources that's needed for community engagement. And so I'll shift here, which is to say that as we've deepened our work within Transitions Clinic Network in 2020, I had the opportunity to kick off the SEICHE Center for Health Justice. It's a partnership between the Yale School of Medicine and the Yale Law School, where we're really explicitly trying to focus on ending mass incarceration. And our work is grounded, as I mentioned, in the provision of care and clinical care in the patients that we see at Transitions Clinic Network. And then this then informs our research, our education, and legal scholarship and advocacy. Our center's name comes from a SEICHE wave, so it's not an acronym, and it's illustrated here. And I like mentioning it. Actually, it's not an idea that came from me, but from our team. It's a wave that emerges from stagnant water and results from two waves that are traveling in opposite directions, trying to disrupt the status quo. And so the center in its conception is really trying to disrupt the status quo between two systems that are often siloed, the carceral health system, as well as the community healthcare system, with explicit goal of dismantling mass incarceration. And at its core, when we were founded, the Yale faculty, staff, and students, the majority of our center has personally been impacted by mass incarceration. And so this is a different place, I think, to really do research, but it's also one that keeps the questions urgent and honest. And so early on in our formation, we really, driven by the energies of Jerry Smart, wanted to tackle the kind of primary causes of death in this population. Again, as I mentioned, there's not a lot of science that guides even why individuals have higher risks for many of these health outcomes. And so we kind of tackled many of the primary drivers of death. For the remainder of this talk, I wanted to focus on our work in gun violence because it's one that is rooted in an almost 10-year-long academic and community partnership. And this is one, again, that started with funding from the Robert Wood Johnson Clinical Scholars Program, and then subsequently has been funded by 2 rounds of R01s. And this here is a picture of New Haven, and I'll use this to kind of illustrate another project that we've taken on using CBPR. There's a picture of New Haven, and in 2013, when this project started, New Haven, like many cities, was beset by community gun violence. And it was community partners that really wanted us to study specifically what assets exist in the community that are protective of gun violence. They wanted to lead the interventions themselves. All too often, there's lots of interventions now focused and led by police or government, but very few that were led by community members themselves. And so at the project's core, we worked on finding a broad stakeholder group, and we've engaged a diverse group with different perspectives on the problem. This includes people from all over New Haven, including different sectors, and even, really diverse in our political leanings, our gun ownership, and explicitly recognizing that if we're really going to tackle complex problems, then we need to have kind of a very diverse group, sets of ideas that are represented at the table. And so as a start, our group was really committed to using local data to understand what exposure to violence was in the community. And explicitly, we're interested in taking an assets-based approach, and had the hypothesis that, again, Sampson did in the almost 30 years ago, that was published in Science, that social cohesion and collective efficacy were associated with decreased exposure to gun violence in our community. And so we trained 55 community members to go house to house, asking some basic questions, trying to understand this landscape in New Haven. And some of the questions were ones that, are similar to, again, Sampson's original study. And what we found was that, not surprisingly, exposure to violence was quite high in these communities with high rates of incarceration. 95% had heard a gunshot. 33% of respondents had been seen, were present when someone was actually shot. They wanted to ask questions about community preparedness for gun violence. I think that this is just an example of some of the questions that came from our stakeholders, from community members themselves. And so, I would not have thought that individuals prepared at this level for community gun violence, but many would share that, in fact, individuals that live in communities where rates of gun violence are high often do buy burial insurance for their adult family members or even kids. And when we asked, and this kind of blew me away, that almost 30% of those that were interviewed had purchased burial insurance for a child in their family, given worries that they would be killed by community gun violence. And then for the primary hypothesis we are testing, we did find, as the original study showed, that if higher rates of social cohesion, higher rates of collective efficacy in one's neighborhood was associated with lower rates of having been exposed to gun violence. And so we're eager to move forward in this, of thinking about kind of how community assets could prevent gun violence, and ended up, again, submitting for an R01 that we are ultimately awarded. And I think the first thing that I wanted to mention here is that we intended to use a participatory process, to have a community organization apply as a multi-PI, and there just simply wasn't an organization that had kind of the financial, even the accounting processes in place to take on a federal grant. And so we went in Yale on its own. And here, what we decided to do was instead use social network analysis and spatial network analysis and identify areas and people that the probabilities would look like they had been involved in gun violence. And in fact, they hadn't been. And do qualitative interviews, understanding what resources, how have you been able to avoid being involved in gun violence? And if from a spatial network analysis, again, what community resources, what assets exist on the block level that have made this block safer than others? And so really using local data to tell a new story and engage in a different science that was really focused on positive deviance that was informing gun violence interventions. And so some of this interviews revealed that home ownership and access and uptake of behavioral health programs were key components for them having avoided gun violence. And in the interest of time, I won't read these quotes. We then created causal loop diagrams, and again, group participatory modeling to look at specifically what were the factors that were associated with exposure to gun violence. And again, the same themes came up from our qualitative interviews as came up in the group participatory model building. And so in this first R01, took the opportunity to learn from our colleagues at UNC, from Dr. Giselle Corby's team, and specifically brought them in to start working with our community partners about how best to engage in community engaged research, what kind of infrastructure needed to be in place to participate in federal grants. And so I'm proud to announce that we did get our next R01, and this time had an MPI that was a community partner, Miss Virginia Spell, who is Executive Director of the Urban League of Southern Connecticut, and now are testing again in a step wedge neighborhood clustered trial, how providing home loans to individuals whose family members are incarcerated or first and last month's rent, and also at the community level, providing more mental health support for individuals that have been exposed to gun violence might change exposure to gun violence at the neighborhood level. I'm just going to skip this. And so some challenges that we found here is that, of course, community organizations didn't have an at-risk. They need to invoice monthly, that the structures, the NIH at the university have been incredibly painfully slow. And this isn't news, I don't think, to anyone, but it also is not it's a challenge that has existed and has still yet not been solved. It's been difficult, again, for us to align data collection with the daily operation of the community organization. And importantly, one of the big goals of having an MPI that is a community lead was that we could start participatory budgeting, that the community organization could renegotiate their federal indirect rate. So instead of the 10% they could get, could start getting the 70% that Yale gets. And this has been nearly impossible for us to negotiate. Some good stuff that's emerged, though, from this work, and I'm happy to share, is that through my time at Yale, we've been increasingly pushing the hiring policies and practices, and especially if the science is better with incarcerated people and formerly incarcerated people informing the science, working alongside us at the SEICHE Center, then there ought to be the policies and practices that are at the university that similarly support them through the application process. When I started at Yale, there was no written, transparent hiring policy for people with criminal records. And after 8 years of working with our legal and HR department, have one that is really kind of closer to a fair chance hiring that was just recently posted on the Yale website. I'm happy to talk more about that. We also have worked towards getting new center-affiliated faculty. Again, Deanna Hoskins, the different grant that we have, is formerly incarcerated and is the first faculty member at Yale that has a criminal record, and got her through the appointment process. And now she's working closely with us, the School of Medicine, and lots of initiatives, but also the School of Management, where she's designing a new program to train formerly incarcerated. We're at the beginning parts of talking about a new program training formerly incarcerated community-based organization leaders to develop management skills. And so, again, it's through this process of CBPR that we can start changing kind of who works at Yale and also whose expertise is informing the education programs that exist at Yale. And so I'm going to end with some concluding thoughts. CBPR is an approach that has kept our science really honest, urgent, shifts powers, and thus leads to sustained change. And, you know, in my experience, it's been useful to challenging hierarchies in healthcare. So if you have an evidence-based model that requires hiring a community health worker that has a criminal record, then HR has to interrogate their HR policies. And similarly, within research, universities, too, are now having to interrogate their policies And it's both through kind of building evidence, but also through relationships that we've been able to make these changes. And this part, not all the research that we're doing is using a CBPR approach. It's incredibly challenging, but it's probably been the place of most personal growth and joy. And so I'm ending here with a letter that came from behind bars. And what really remains untested for me, and I think is a place for research, if done well, is CBPR in prison. And so during the peak of COVID-19, when our team was conducting webinars on COVID, and especially access to vaccine trials in prisons, we received this letter from an incarcerated student behind bars. We are streaming our webinars behind bars. And having listened to our seminar, he writes that he had an idea, a study. Another suggestion that I have would, quote, follow my questionnaire, of course, after gleaning data from it, would be to set up a pilot program of inmate volunteers who would either participate in ongoing clinical trials for COVID-19 or any virus for that matter. And it goes on and on. It was 38 pages of a brilliant letter. And this isn't pertinent just to COVID. Many of the conditions that incarcerated people have, they have higher rates of morbidity, mortality, and yet can't participate in studies or even clinical trials. And this letter for me raises again the important question of who's excluded from research, who reaps the benefits of research, and why incarcerated people have never been included in decisions about scientific governance. And it's the promise for me of upending a carceral system that has me most fired up about trying CBPR behind bars, and especially bringing the brilliance, the expertise of those currently incarcerated into our science, really informing the health of our community. So I'll stop here and thank you so much for the time. Sorry, I think I've gone long a little bit, but really appreciate the opportunity to be here.
Thank you so much, Emily. You're actually just on time, and that was really, really fantastic. I tried to hear you speak whenever humanly possible, and I always learn something new. So thank you very much. We do have, I think, a couple minutes for a few questions that were posed in the chat. So I'll start with this one. Great talk. Can you speak more about how you built relationships with the people on the community advisory board?
Yeah, I think that this is great. So some of where building community advisory boards, I think that there's a whole literature around this. One of the things that we really tried to do is first go to kind of trusted members within the community. So formerly incarcerated leaders. Again, I mentioned there was two groups, All of Us or None, and Legal Services for Prisoners with Children, who were kind of the most trusted collaborators, and went to them trying to identify individuals that they thought understood kind of the needs of people that were incarcerated, were allies, so to speak, within government, within even the carceral system, within the Department of Public Health, et cetera. And so kind of recognizing, again, the hierarchies we're trying to unearth, then built our community advisory board. Specifically, we really did try to both have kind of especially in the later community advisory boards, a larger diversity of kind of peoples at the table that would reflect different sorts of opinions. They still had to be trusted. We still had to kind of respect each other, but we had to create more spaces for conflict. And I think the initial community advisory board was a place where there was less conflict, and then increasingly, as we've taken on kind of harder and harder topics, we have really tried to bring in more and more people to the table. And so, there's only community advisory boards are like they could grow, and then it becomes a little bit too unwieldy, but that's a starting point. So, one thing I'll add on is that recently our work has tried to, actually we're taking on explicitly that if we're saying that carceral systems are health harming, then they also have been explicitly health harming to those that work in carceral systems. And so those partnerships between incarcerated people, formerly incarcerated people, and correctional workers actually has been a really interesting place at the SEICHE Center.
Thank you. I think I'll go over time for one more question, just because this is so interesting, related to your last point. There's a question, are there specific strategies you've seen to be the most effective at reducing those health-harming behaviors that are rampant within the carceral system? If so, are these strategies that can also be beneficial to patients that are transitioning from the carceral system to the community healthcare systems?
Yeah, I think there's kind of countless ways to answer that, partially because I do think that there's so little that's known around kind of carceral system health. And so, a lot of my interest and excitement, is around these 1115 waivers, and so you've written about them brilliantly, is just bringing the normal behind bars. So there's nothing crazy about bringing Medicaid in, but what Medicaid then does is create a system of oversight, a system of quality measures. And so it's not mind-blowing what's going to happen. And, many people have written about the deficiencies in Medicaid, but just bringing normal behind bars where, again, hopefully healthcare is then overseen by healthcare providers, by kind of people that are just squarely focused on quality of care, I think will transform care. And so the things that have been most transformative to me are real simple things, right? That, and they could range, oh, there's that weird Zoom thing, sorry. They could range from bringing the 3 FDA-approved medications for opioid use disorder behind bars. They're already FDA approved. How do we bring those behind bars? Or, again, basic things like electronic health records behind bars. These are the things that I think are the most transformative, and it's nothing kind of real out there. It's bringing what we know already works behind bars and making that system more transparent.
Absolutely. And other than the 1115 waivers, are there any other proposed legislation or kind of policy proposals that may, force some sort of accountability in the quality of healthcare that's delivered in correctional facilities?
Well, I think that there's a couple things that are coming down the pike. So, and two that I'll speak to maybe right now, which is for the first time, the American College of Graduate Medical Education has approved a carceral medicine fellowship. And so again, this creates a training pathway for individuals that are interested in the care of people behind bars. They have to be accredited, hopefully, to be able to practice behind bars. And it creates kind of a new gravitas for the unique systems of care within prisons and jails. And so the first kind of round of fellowships the applications are happening this summer, and then there'll be the first round. And, I feel, I think it's important, again, why shouldn't individuals when they're incarcerated have physicians that are boarded, that are trained to take care of that population? And also there's so much more that needs to be done, but I think that that's one important thing to flag, is that the ACGME is now creating a carceral medicine fellowship. And then secondly, different than the 1115 waivers, Congress has mandated for young folks that are incarcerated, juveniles, so again, below the ages of 21, that care Medicaid can be continued through the course of the carceral stay. And if you're under foster care, if you were kind of a ward of foster care, then that can continue through 25 years of age. And so this will force our nation's carceral systems to have to contend for all their young individuals that are incarcerated, so young adults up to 25, to start working on how it is that, again, there need to be more communications between the community health systems and the carceral systems. And so this will start, I think, the process, again, with the 1115 waivers, which are not mandatory, they're voluntary, and they only last for 5 years. What I'm discussing for young folks that are incarcerated is that that'll force our nation's 6,000 plus facilities to have to be in conversation and in communication with community health systems.
Great. Thank you. In the interest of time, although I could probably ask you questions for hours to come, we will wrap up today's session, but just want to thank you so much on behalf of IHER and the entire community for all the work that you do, for sharing your brilliance, and for bringing up so many people along with you as you continue the fight.
I wanted to thank you and IHER just for this amazing opportunity. And it's, folks like you and Dr. Holliday at IHER that are really leading the way in the work that is yet to come. And so just really appreciate you all and the invitation to be here today. Thank you so much.
Thank you. Thanks everyone for attending.